also has some inflammation, benign tumors, and malignant tumors, and some abnormalities. So breast, even though it is small, but it has several diseases, such as inflammation, benign tumors, anomalies, metastatic cancer, and the others. So now let us see what we call fibrocytic changes. This is some cystic changes in the breast. Some they produce a palpable mass known as lump. In case of fibrocytic changes, there is exaggeration and distortion of cyclic changes that occur normally in the menstrual period. So they may cause some nodularity and some small lumps, as we said before. Because this one, it is a theory, we will see them in practice. A fibrocytic change, physically, it is a palpable mass. In the consultation, you can't say this is a fibrocytic changes. For this one, you have to make a biopsy, then you send the biopsy for the lab. Then a pathology will confirm it is a fibrocytic changes. But physically, on physical examination, you can't say this is a fibrocytic change. You just describe an image, tumor fixed or mobile around 3 centimeters in the upper quadrant, like that. Fibrocytic changes will be given by the pathologist. So there is what we call proliferative changes. This they concern about the epithelial hypoplasia. This epithelium can be on the duct and the breast gland. So they say it is proliferative lesion within ductile, terminal ducts, and sometimes the whole lobule of the breast. So meaning that it is about on the epithelium. In this one, they say some epithelial hypoplasia are mid-order and can carry a little risk of carcinoma. Doesn't mean all epithelial hypoplasia will lead to carcinoma. No. Some they don't develop to carcinoma. And as I said before, on a physical examination, you can't say this is epithelial hypoplasia. It is after taking the biopsy that will say this is epithelial hypoplasia. They say epithelial hypoplasia are often accompanied by other histiocytic variant of fibrocytic changes. There is another one, tumor called sclerosing adenosis. This one on the microscope, when you are young in pathology, you can say this is a carcinoma. Whereas it is not a carcinoma because they can mimic a carcinoma, even clinically and even macroscopically. It is less common than cyst and hyperplasia. But the problem is clinical features, microscopic features, they are similar to the carcinoma. This is why we pay attention on sclerosing adenosis. Inflammation, these are common and they're known as mastitis. There are several forms of mastitis and traumatic fat necrosis. Fat necrosis I've seen in general pathology. In breast, there is what we call fat necrosis. This also can mimic carcinoma. And those that are not associated with an increased risk of cancer. This is what we call mammary duct ectasia or periductal or plasma cell mastitis. This one is uncommon. And this is characterized by induration of breast substance. They can mimic the changes caused by carcinoma. So in summary, the tumor depends on the tissue involved. It can be from the epithelial cells or from the connective tissue. But most of the time, they are from epithelial tissue. The most common tumor in young female before 25, it is known as a fibroadenoma. Fibroadenoma is a benign tumor of breast. It is a benign. They say they almost never become malignant. Most of the time it is benign. They say it is because it's caused by an increase in estrogen activity, which contributes to that development of that proliferation of gland and fibrous. Similar lesion may appear as the fibrocytic changes, kind of have fibroadenoma with cystic changes. Those fibroadenoma physically, they are mobile, irregular, and non-tender. There are some other tumors similar to fibroadenoma. They are called Fibroadenoma tumor. They are less common than fibroadenoma, and also they are diagnosed on the microscopy. As well say this is a fibrocytic, fibroadenoma tumors. Most of the time they are benign, but there are some cases with malignant. There is another tumor called Intraducto papilloma. This is a benign tumor. They are solitary and found within the principal lactiferous duct or sinus. Clinically, the appearance of serous or bloody nipple discharge is some discharge. Is a sorry, there was a problem of internet connection. Can you hear me?
Yes, we can.
Okay. In the case of intraductal papilloma, nipple retraction is very rare. Most of the time they are benign. This is the range of ductal carcinoma in situ. You see the normal cells, ductal hypoplasia, atypical hypoplasia, ductal carcinoma in situ, ductal carcinoma with microinvasion, and invasive ductal carcinoma. In our daily practice, the challenge to differentiate atypical hypoplasia, ductal carcinoma in situ, and ductal carcinoma in situ with microinvasion. This is a big challenge on the microscope. Even on the clinic, they are similar. A carcinoma, most time, a cancer found in the breast is ductal carcinoma. Can also found lobular carcinoma, but the most common is ductal carcinoma. Ductal carcinoma, it has several subtypes. It can be tubular, mucinous, metaplastic, inflammatory, medullary. There are several subtypes. The range of having the breast cancer, most of the time it is around 40 years. This one geographical distribution, it depends on the country. The age, I have said it is around 40, like that. But we have seen one case of breast cancer in a 9-year-old female. So this is to say that is not ruled is about that even in younger can found carcinoma. Another one you must know it is that 5 to 10% of breast cancer are related to inherited mutation, what we call BLAC1 and BLAC2. Those one there's mutation of BLAC1 genes, and this one there is gene function in the DNA repair. This is why I found a cancer. We can do the check if there is a risk of having a cancer in the family. In the case also of breast, we measure also the tumor suppressor P63, but there is a long list of genes involved in the cancer, but the most common is BLAC1 and BLAC2. Another cause is exposure to exogenous estrogen based menopausal and some oral contraceptives. You know, in the case of menopause, for the treatment, they add the estrogen to maintain the physiological parameters by adding estrogen. Oral contraceptives, they can also cause the cancer, radiation, obesity, alcohol consumption, and that high rich in fat. So in summary, breast cancer risk, there is geographical factors, age, family history of those mutations, age at menarche less than 12, age at menopause over 55, first life with birth pregnancy age of 35, nalparas, and some benign causes that go to the causes. These they are risk factors. Place where established influence exogenous estrogen, oral contraceptive, obesity, high fat diet, alcohol consumption, cigarette smoking. Pathogenesis, overexpression of what we call HER2, human epithelial receptor 2, proto-oncogene to be amplified. Are we together?
Yes.
Are we together?
Yes, we are.
Are we together?
Yes, sir.
Are we together?
Yes, Prof.
Are we together?
Yes, Prof. We are together.
Are we together?
Yes.
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 Hello?
Yes.
Are we together?
Yes, Prof. We are listening.
Hello, good afternoon. Are we together?
Yes, Prof.
Okay. There was a problem of internet connection. Well, in this slide, where I said that in pathogenesis of breast carcinoma, there's genetic changes in a 5 to 10%. With that expression of so what you must know for the breast, when we diagnose a breast ductal carcinoma, there are 3 elements we test for guiding of the treatment. Those are estrogen, progesterone receptors, and this one HER2 new. These are 3 after diagnosing the breast carcinoma. Immediately we did the immunohistochemistry of estrogen receptors, progesterone receptors, and the HER2 new receptors. Once estrogen and progesterone receptors are positive, they give a treatment which responds to the. So they use the treatment which corresponds to that level of the progesterone and the estrogen, meaning that once estrogen and progesterone are positive, it means that there is a good prognosis. HER2 new, when it is expressed, even though there is a treatment, but there is a poor prognosis. Estrogen receptors and progesterone receptors, once are positive, they give a treatment with the component of estrogen and the receptors. This is why we go in subtype of into 5 subtypes. Ruminal age. Ruminal age is when both estrogen and the progesterone are positive. Ruminal age is when estrogen are negative and the HER2 new is positive. And there are some cases all 3 are negative. This is what we call triple negative. Triple negative is when estrogen, progesterone, HER2 new are negative. In that case, we call it triple negative and it has a poor prognosis. In the pathogenesis also there's hormonal influences. Endogenous estrogen excess or hormonal imbalance has a significant role. It's the same as those hormone estrogen and the progesterone. They have a role in the breast carcinoma. Environmental variables like those radiation and exogenous estrogen, they are also involved. So now let us see the spread of breast cancer metastasis. The spread occurs through the lymphatic and hematogenous channels. Lymph node metastases are present in about 40%. This one is lymph node metastasis. They present a palpable mass. Outer quadrant and central located region typically spread to the axillary lymph node. Like those in the inner quadrant often involve the lymph node along the internal mammary artery. There are also some clavicular nodes. Metastatic also may involve other organs such as lung, skeleton, liver, brain, spleen, and pituitary. Clinical manifestation, maybe this one it is better we see them on physical examination. We see them in practice where there is oozing like a lump, hard, what we call pod orange. This is a characteristic of breast carcinoma. Swelling, dimpling of the nipple, dimpling irritation of the skin, and nipple discharge. But what you must know, those non-tender lumps, most of the time they are malignant, but you have to confirm with a biopsy. In the clinical course, breast cancer is often discovered by the woman or physician as discrete, solitary, painless, movable mass. Most of the time, you will see a patient will come, I have palpated a mass in the breast. So immediately they come to see the physician. This is why, for the public health, we do a self-palpation of breast lumps. When there is regional involvement, this one it is an advanced. But what we have seen most of the time, the people they consult when there is even metastasis at an advanced stage. For the screening, you can use mammography screening, ultrasound, but the most common and cheapest is the mammography, radiograph of the breast. The prognosis of breast carcinoma is influenced by following variables: size of the primary carcinoma. For example, if it is less than 1 centimeter, this one have an excellent prognosis. Lymph node involvement and the number of lymph nodes involved. Once there is metastasis in lymph node, this one, there is a poor prognosis. Distance metastasis spread to other organ. They have poor prognosis and rare curable. A grade of the carcinoma. For grading the breast, there is a score to grade the breast. Nottingham score, it is what called Nottingham score, where we see the tubule formation, nuclear grade, and the mitotic rate. This one will help for grading of the breast carcinoma. Histologic type, as I have said, breast ductal carcinoma, it can be tubular, medullary, cribriform, adenocystic, and mucinous, and the others. Those have a better prognosis than carcinoma of non-special type. And the most one with good prognosis is tubular carcinoma. This one has a good prognosis. And this is why when you diagnose breast ductal carcinoma, you must also say subtype to predict the prognosis. Presence or absence of estrogen receptors. This one I have said before. Once you found the breast ductal carcinoma, immediately you go for the staining of estrogen and progesterone receptors. The presence of those receptors confer a slightly better prognosis. Proliferative rate of cancer. High proliferative rate are associated with a poor prognosis. Aneuploid carcinoma for abnormal DNA content have a slightly worse prognosis. Overexpression of HER2/neu. This one also, even though it is treatment, but it has a poor prognosis. Major prognostic factors also used by American Joint Committee on Cancer for staging of breast carcinoma. Remember that stage 1 and stage 2 are early stage, stage 3 and 4 are advanced stage. I don't want to memorize staging. This one you can know it in practice. You can't memorize. Because when we are reading some slides, there are some guidance and aid memoir for staging.
Hola.
Hello, are we together?
Yes.
Okay, we are just about saying the staging of the cancer. Staging also will, prognosis also depend on the stage. Early stage, they have good prognosis. Advanced stage, they have poor prognosis. We have said breast is in male and female. We can have what we call gynecomastia. This is an increase of breast size in male. This one, gynecomastia, may occur in response to estrogen excess. Histologically, the breast of the male and the female, it is similar. The problem is that for female, it is more developed than male. Can have gynecomastia in case of cirrhosis of the liver, consequence of inability of liver to metabolize estrogen. Morphological features are similar that to intraductal hypoplasia. So don't be surprised when you say there is a breast cancer in a male. It is normal. But females are on high risk than male for having breast carcinoma. This is what it is. Carcinoma in male, it is 1/125 female. Morphologically, it is similar. They resemble invasive carcinoma in female, both morphologically and biologically. Let us see some diagnostic technique, treatment, and procedure. Breast self-examination. This one is taught in the public health. For all female, they have to do their self-palpation. Mammograph is like radiograph, it is like X-ray. This one also can detect some various and malignant lesion before they can be felt. Even if it is not palpable on the mammograph, you can see some calcification and the other benign tumors. Aspiration, as we say, FNA, fine needle aspiration, is done for screening because it is direct. You can have the diagnosis in 30 minutes. Then it can tell you it is benign or it is malignant. And after that, you can do a biopsy. Then you examine tissue on microscope. After that, maybe it is not added. Also, immunohistochemistry is added for estrogen, progesterone receptors in the heart new. And also you can see some molecular test. So this is about the breast. Take-home message is that the most common tumor under 25 years, it is the Fibro Adenoma. The most common carcinoma is ductal carcinoma. And there is also a lobular carcinoma. And that ductal carcinoma, there's some subtype. Medullary, mucinous, cribriform, medullary. Those, they have a good prognosis than non-specified ductal carcinoma. Another one is that after diagnosing, you have to do the stain of 3 antibodies: estrogen receptors, progesterone receptors, and HER2 new. And after diagnosis, also you have to give the grade by the mitosis, the clear morphology, and the tubule. And also you do a staging. For the treatment, when it is the lump, we do a lumpectomy. When there is a lymph node axilla involved, then you do radical mastectomy. And what you must know, 5 to 10%, they have genetic factors in developing of breast carcinoma. So This is the take-home message. Any question? Any question? Any question? Any question? No question?
No question.
No question. I can show you on this link some image, for example, a fibroadenoma. Macroscopically, it is like this one. And then on microscope, it is like this one. You do those secretory unit of the breast, fibrous tissue here. For example, here it is intercalacular. If those elongated, ductal, and here there is fibers. Here they say carcinoma rising in Fibroadenoma. Here there's some mucinous. A fibrocytic change. You see how it looks on the microscope. Even you can see some cystic lesion on the microscope. And this one is the cyst. Let us see the sclerosing adenosis. This one can mimic a carcinoma. But you have some antibodies like SMA P63 to differentiate sclerosing adenoma from the carcinoma. Papillary carcinoma. These are intracytic papillary carcinoma. This is a carcinoma. A mucinous choroid carcinoma. This one, whitish material, it is a mucin. This one, the mucin, these are malignant cells. But to be clear, I have to make it bigger. See the solid nest trabecular cubiform in the papillary pattern. This then whitish is mucin. Target disease. You see this one? These are mammary target disease. You see now the lesion. When you look at this lesion on the breast, you can't know what is this, but you have to make a biopsy, and then you go for the microscope, and you find like this one. These are target disease, target cells on the nipple, meaning that malignant cells are also found on the nipple, and this one is an indicator of poor prognosis. Let us see the lobular carcinoma. You see now it involves the lobule. And the characteristic also here, there's what we call Indian file. This is the characteristic of lobular carcinoma. To differentiate, we use lobular carcinoma from ductal carcinoma with antibody called ilcaderin. This one will be positive in lobular carcinoma. Let us see the molecular classification of breast cancer. What you have seen, the lamina A, Nabi, HER2, Licht, Bezo-like, but this one at your level, what you must know is the estrogen receptors, progesterone, and HER2 new. Those classification of lumino A, lumino B, it is advanced. It is for the pathologist, and this will come with the experience. Serranous carcinoma. These are carcinoid tumors, endocrine tumor. Signet ring cell carcinoma, but those are rare. Here there are some rare breast tumors like those fibroid tumors, martoma, hematofibrosarcoma, metastasis, plasma cell mastitis. So once you have a time, you can go through those links. I have shared even those links in general pathology, but I will again share with you. Any question? Any question? Any question?
No question, I guess.
Okay. So next time, because you have the access on the Moodle, I can bring some images, not complicated. For example, like this one. I can ask you to do a description and to tell me if it is malignant or benign. Okay? I can bring an image like this one. Like this one. And immediately, I ask you what is the diagnosis. So I will add some images on the Moodle, then you have to comment on those images. I will also add some short answer question on the Moodle, then you go for it and you do some exercise. But pathology is very big. I will pick the most important and the most common. Because if I ask everything, you will not have time to memorize. So you will pick the most important. If there is no question, we can stop here, then we continue next week.
Thank you, Reg. I appreciate.
Okay. Okay. Thank you. See you next week. And if I don't remember to share with you the next topic, please write it to me and ask me what is the next presentation, then I will let you know. Okay?
Yes, Prof.
Okay. Okay. Bye-bye.
Bye bye.